Welcome to the Royal College of Physicians Edinburgh Clinical Conversations podcast. Each episode within this podcast series, we delve into a different medical topic with an expert speaker to join us. If you want to find more about the Royal College, then please do head over to the RCPE website and have a look at the education stream and see if membership would work for you. It offers a host of educational updates and activities such as the evening medical updates, the Royal College Symposia, and many more. Please don't forget, if you listen to our podcast, to give us a rating on one of the podcast platforms or subscribe so that it can come directly into your podcast stream.
Hi, and welcome to this episode of Clinical Conversations brought to you by the Royal College of Physicians of Edinburgh Trainee and Members Committee. My name's Kat Ralston. I'm a member of the T&MC and a geriatric medicine registrar in Edinburgh. And today I'm delighted to be joined by Dr Alan Japp to talk through a practical guide to heart failure with reduced ejection fraction. Alan's a consultant cardiologist and lead for heart failure in NHS Lothian and the National Clinical Lead for Heart Failure in Scotland. Thanks so much for joining us, Alan.
No problem, Kat. Really nice to be here. Thanks for the invitation.
So I thought it might be useful just to start with why we're talking about heart failure with reduced ejection fraction. What's important about it?
Well, I suppose heart failure with reduced ejection fraction is what most people think of when they think of heart failure. It's a sort of classic paradigm of heart failure where the heart pumping function has become weaker, and then that leads to the downstream consequences of congestion, breathlessness, edema, and all the clinical signs and symptoms you associate with heart failure. There are other forms of heart failure where there are other factors at work. And so there's been a classification of heart failure into different groups. So there's heart failure with reduced ejection fraction, which is patients who have clinical heart failure and also have an LV ejection fraction less than 40%. Then there's a sort of strange group called heart failure with mildly reduced ejection fraction, which is just really what we call mild LVSD, where the ejection fraction is between 40 and 59%. And then there's another group called heart failure with preserved ejection fraction, where the LV ejection fraction is above 50%, but for some reason these patients still develop a heart failure syndrome. So heart failure with reduced ejection fraction is important because that's this sort of huge evidence base we know about for heart failure. All the drug therapies that have been really successful over the last few decades were all tested in heart failure with reduced ejection fraction, and specifically in patients with quite severely impaired LV function. There was a bit of a gap in treatments available for other forms of heart failure, or a gap in the evidence base with multiple failed trials. That's changed a lot recently, but still heart failure with reduced ejection fraction is the area where we can make the most difference and where we've got the best therapies.
Thanks. That's really helpful. So I think that kind of outlines why it's important to make a distinction between the different types of heart failure, because it's going to really alter how you manage these patients.
It absolutely does. The key to it is there's a prognosis thing. There is a relationship between lower ejection fraction and adverse prognosis, but the key is that it guides the therapies that you're going to give.
Yeah, and you've already kind of alluded to making the diagnosis of heart failure with reduced ejection fraction, but can you just quickly talk us through what kind of things you're looking for to make that diagnosis?
When you start talking about that, everybody immediately starts thinking biomarkers like NT-proBNP and echocardiogram. But I always think it's worth just stepping back a little bit and thinking about what's the sort of clinical features that you're looking for. And say for patients who are not crashingly unwell, but have got new onset breathlessness, when are you thinking heart failure? And probably it's the most important aspect of making the diagnosis is to think about it as a possibility. And I think there are certain tips. Tends to run a sort of subacute type course, generally not someone who's been breathless for 2 years, and it's not somebody who's been breathless for 24 hours. It's often over, say, 2 or 3 weeks of progressively worsening breathlessness. A really helpful sign is breathlessness in bed at night, orthopnea or PND. We all learned that at medical school, but in real life, it's a super helpful sign. Don't be put off by people who describe PND as a kind of tightness in their chest when they sit up. If somebody's getting tightness in their chest every night and waking up with it, that's heart failure, it's not angina. For patients who have breathlessness with new onset ankle swelling, that combination of symptoms is really suggestive, particularly in males. Elderly females tend to get ankle swelling a little bit easier. It's not always quite as good a symptom there, but it is in younger patients and always in males. Any response to loop diuretic is really helpful. about 80% of patients with heart failure will tell you that they were given some miracle drug and it made them suddenly feel better. It was like a magic wand, and that's, almost diagnostic as well. So there's a couple of things to think about there in the history. Don't always be put off by the demographic. Heart failure can affect young people as well as older people. It's often missed in younger people. And, if somebody's got worsening breathlessness for 2 to 3 weeks, it's not a pneumonia, it's not a chest infection. There's no point giving antibiotics. It's not that. Why would we think asthma? I think sometimes it's just because people make that diagnosis because they feel unsafe for terrain. But there's loads of help available if you think it's heart failure. You just have to think about it, and then you have to think about making the diagnosis. In Lothian, the next step for, say, people in primary care would be to send in a referral for suspected heart failure, and along with that, you send in a blood test that we check NT-proBNP. BNP is a physiological hormone that's released when the ventricles of the heart are stretched, particularly the left ventricle, so they're trying to be filled more than they want to be filled, which is the essence of heart failure. They've got a physiological role. They sort of help to promote things like sodium loss, vasorelaxation. So they're helpful, but they're helpful diagnostically as well because they are released in heart failure. They've got diagnostic significance and prognostic significance. So the recommended threshold for NT-proBNP is that if it's above 400, that you need to consider heart failure and investigate further. If it's above 2,000, you ought to do so more urgently. Its recommended timescales are an echo within 6 weeks. If it's between 400 and 2,000, within 2 weeks if it's above 2,000, because that's somebody who may be about to decompensate. And when it's less than 400, it's very unlikely to be heart failure. So that is kind of a useful test. The only problem is that NT-proBNP isn't specific for heart failure, and it also goes up with advancing age, with hypertensive heart disease, with AF, levels about 3 to 4-fold higher in AF than in sinus rhythm, and with chronic kidney disease, where levels can be way up, even in the absence of heart failure, anemia and some other conditions. So if you start sort of checking NT-proBNP routinely in all sort of 80 and 90-year-olds, then BNP is going to be raised in an awful lot of them. And that can lead to problems with pressures on the echo service and slowing the whole process down. So I think going back a step and thinking, is this heart failure or is there an alternative obvious diagnosis here, before just going through the whole panel of diagnostics, is the place to start. Once you've got clinical suspicion of heart failure and that's not been ruled out by the NT-proBNP, there's a couple of other tests that are helpful. The 12-lead ECG is really helpful. If the 12-lead ECG is normal, it's almost as good a rule out as a BNP. If it's abnormal, it's another marker. Left bundle branch block is a really important one to find out. Left bundle branch block is much, much more commonly associated with heart failure than with ischemic heart disease. So we always think about MI, but it's almost never that. But it is often a signifier of heart failure. Or non-specific changes, so LVH type pattern with LV strains, a really common one, frequent ectopic beats, and atrial fibrillation as well. So these are important clues. And then we then get an echocardiogram, and that can help make the diagnosis in a number of ways. Crucially, it tells you about the LV ejection fraction, but it can also tell you about other phenotypes of heart failure and other mechanisms, valve disease, pericardial constriction, HF-pEF, HF-rEFerence, preserved ejection fraction type phenotypes, where there's subtle clues on the echo as well. So then the echo becomes a really important test. In the acute setting, in NHS Lothian at the moment, we don't have NT-proBNP at the front door. A lot of other people do. Probably even less specific in patients presenting acutely unwell, because NT-proBNP does go up, perhaps a wee bit like troponin, when we see some of these high sensitivity troponin assays, and they're not always specific these days for MI. But it can be a useful test to exclude heart failure in some patients at the front door. But the chest X-ray is really helpful in patients present with acute dyspnea, and there's often clues there. And again, those clinical signs, PND, orthopnea, ankle edema. Really the most helpful clinical sign in practice at the front door is the JVP. Really crucial. I really would urge people to just spend a wee bit of time on the JVP. It isn't all that hard. We've got this sort of mystique built up around it, but it's actually really, really easy. It's the best guide. If you see somebody with edema and you can confidently say the JVP's up, then you know they've got cardiogenic edema. If you can see confidently that the JVP isn't up, it's not heart failure, it's something else that's causing the edema. It's a really useful thing to also titrate your therapies to like your diuretics. In the outpatient setting, listening to the chest is not actually all that helpful, because hardly any patients with heart failure in the outpatient setting have pulmonary edema. But in the acute setting, obviously that's really helpful. And then again, sort of think about expedited echo as soon as possible. If you think you've got somebody with decompensated heart failure in hospital, contact your heart failure team check an echocardiogram to try and confirm the diagnosis. So that's my sort of rough and ready approach to diagnosis.
Thanks, that's so helpful. And I think it's really important, just as a reminder, that we can't take tests in isolation. So having the clinical picture, the pretest probability before the sound test like the pro-BNP is just so useful. So yeah, thanks for the reminder for that. I want to pick up on a couple of things. One question that I often get asked is, they might have had an echo a couple of years ago. When should we be considering a repeat echo, presuming the patient has presented with clinical heart failure?
It does often come up, doesn't it? I think if somebody's got an established diagnosis of heart failure with reduced ejection fraction, and we know they've got significant LV-SD, LV ejection fraction, less than 40% or so, and then they present with worsening heart failure, there's really not much need for a repeat echo in those circumstances. It doesn't add much unless there's some sort of new doubt about something else that might be going on. For instance, do they have another potential cause of breathlessness? Because sometimes echo can help you differentiate decompensated heart failure from compensated heart failure. But for the most part, it's going to be to say, well, we know this patient's got heart failure, let's just get on and make sure they're adequately treated. You don't also have to repeat it in patients who've presented with a very similar presentation before, who have preserved ejection fraction. It doesn't necessarily follow that they have developed new LV-SD. If they've got heart failure already, then you expect those patients to have decompensations as well, and you don't have to repeat an echo every time. I do think that if somebody has had an echo in the past but has a whole new presentation, maybe the echo was normal before, but this is now something different, then you do need to repeat it. Another indication might be if the ECG's changed a lot. So somebody who previously had a normal ECG and now has a very abnormal ECG, I would think in those circumstances, echo's definitely helpful. There's another area where I often repeat echo, but I guess less relevant for the front door, is that with modern therapy for heart failure, a lot of people, perhaps more than 50% of patients who don't have ischemic cardiomyopathy, get recovery of LV function with treatment. And so I often repeat their echo to see how they're responding to therapy.
That's really helpful. I think a lot of people find the GBP quite tricky. Do you have any top tips for people trying to get better?
Yes, I do. Probably the most important thing is not to do the whole thing to the medical school where you tell the patient to look the other way, look to the side. The key is to get the muscles and the skin over the neck in a relaxed position. So you need to get them comfy with the head rested back on the pillow, and then just a very slight tilt to the side. And then sometimes the skin's still a little bit taut, and it's hard to describe this, but if you press your fingers just below the clavicle on that side and just push up on the skin so that the skin over the neck is relaxed, and then look down into the little groove above the clavicle, you often see the JVP just popping its head above there. You might only see it as the patient breathes out. If you can't see it, lower them a little bit more, or press down on the abdomen to see if the JVP pops up. And then don't be fooled by the one who's got such full neck veins that you're missing the wood for the trees. And sometimes just standing back at the end of the bed, you can see that the neck veins are bulging. Rather than getting in a sort of microscopic look down at the clavicle, it's obvious from the end of the bed. One other tip, hepatojugular reflux I was talking about there, or abdominal jugular reflux. That's a helpful sign to identify the JVP, but can be used clinically to assess volume status. So what happens with heart failure is that you get salt and water retention, so you get an increase in venous volume. Your veins that try to accommodate as much blood as possible, so they relax, so that you get an increase in venous volume without an increase in venous pressure. When the pressure starts to go up in the veins, that's when you see a rise in the JVP. If you get the JVP back down, then you've still probably got an increased venous volume and you've not really decongested the patient yet. So if you want to know about that, where they're storing all that blood is in their deep abdominal veins and hepatic veins. And for those patients, if you press down on their, and I don't know if you do that, but keep the pressure down. If I were to do that to you, Kat, your JVP would bob up for a second or two and then pop back down again, because you're not storing loads and loads of blood volume. Whereas somebody who is, the JVP will go up and it will stay up. It will stay up for 10 seconds or more, and they need more diuretics to get them decongested.
That's such a helpful practical tip. Thanks for sharing your JVP top tips. It might be useful if you've got a case on sort of common patients you see presenting at the front door that you're asked to see in your heart failure specialist capacity.
Yeah, and they come in all different flavours. There's one thing I want to mention because I think it's really common and under-recognised. So a patient recently presented to the ED with new AF, and so referred as new AF, treated as new fast AF, a rate of 150, 160. So for some reason, given IV fluids, as it seems to be done often in AF at the front door, and given rate control beta blockers in this instance, and then became more and more unwell, hypotensive, almost shocked. And if you actually speak to the patient, what they didn't present with was palpitation. They didn't suddenly say, oh, my heart's racing. They had no awareness of the AF. And if you go back, they've had the presentation has become gradually breathless over the last few weeks, and it's getting worse and worse and worse. And then you realise the presentation here is heart failure. It isn't new AF. And that's the most important presentation. And what happens with some patients with AF is that they have no awareness of it. There's such a spectrum in awareness of AF. But for the patients who don't know that they're in AF, they can stay in AF with a rapid ventricular rate for weeks and weeks and weeks. And if they do that, then they can develop something called a tachycardia cardiomyopathy, when your heart is beating at more than, say, 130 beats a minute, 120, 130 beats a minute constantly for 4 or 5 weeks or so or more. Then you start to develop LV systolic dysfunction. I always tell patients it's like a racehorse galloping around the track but never ever getting to slow down or go to a trot. It just always has to keep galloping and gets tired out. And these people can have absolutely terrible, terrible heart function. Their LV ejection fraction, we see 10%, this sort of thing. And giving these patients lots of beta blocker fluids, this is just catastrophic for the management. You have to manage them completely differently. And they've got all the typical symptoms of heart failure. They'll have subtle features of congestion on the chest X-ray. It's not often pulmonary edema, it's often just subtle features. They'll have an elevated GVP, all the signs. And you have to manage that differently. So you have to be cautious, really cautious with how you give the rate control. You probably want to give digoxin. Digoxin and diuretics is usually the first thing you want to give. And only once they're offloaded a bit with diuretics, gradually increase the rate control. The thing about this condition, one reason why it's so important is because that LV ejection fraction will fully recover if you settle down the rate and rhythm and give appropriate treatment. So it will be completely reversible if you can just guide them through this. The LV ejection fraction won't pick up immediately. It'll only pick up over the course of a few months. So if you suddenly rate control them really strictly and they've still got a terrible stroke volume, then they may decompensate. So these patients are common and you have to spot them, and then you have to be careful about how you manage them. And I just think that's one case that's worth pointing out.
Yeah, that's so helpful. I think, again, that just underlines the importance of that really careful history and examination before you go, blasting in with treatment, and having to be particularly thinking about that when patients presenting with AF at the front door. So that's super helpful. And the only other thing I was asking around to see what people find tricky about heart failure, and this kind of congestion versus perfusion sort of profiles came up. So kind of warm and wet, warm and dry, that kind of thing. And I wondered, is that a useful distinction in clinical practice? Does that run through your mind, or is that not something that really resonates?
I think it is helpful to some extent, yep. The warm and wet is probably the easiest to treat. Sort of hypertensive patient, you've got a lot of blood pressure to work with, and the congestion's a problem. You can diurese them, happily get the therapies on board. That's relatively easy. Warm and dry is trickier, but not usually an emergency. So I think you normally just hand these patients, they don't really need to be in hospital. It's more about the sort of outpatient management. But wet and cold is tricky. And that's where people probably find the most problems. Now, in the most extreme form, these are patients who need mechanical support, consideration for advanced therapies. But at a slightly less extreme end, this is really where I keep trying to manage heart failure, because there's this difficult balance sometimes to get. So I'll tell you about a recent patient, 40-year-old man, who'd presented with classic heart failure presentations, gradually worsening breathlessness over 6 to 8 weeks, clear clinical signs of congestion, lots of orthopnea, a very elevated GVP, very wet, but not much blood pressure to work with. And how do you manage that? Well, you start with diuresis. You always start with diuresis. You have to get the patient dry at any cost, because the congestion, if you see that their JVP's up, it's bulging, the same thing's happening in the renal venous system. It's congested as well, and that's impairing renal blood flow. That's what then causes progressive reduction in eGFR in these patients. They've got a rubbish pump, but they've also got huge back pressure on their renal system. So diuresis, diuresis, diuresis. And what you'll see is, in a lot of cases, that when you diurese patients effectively, the GFR will come up because you are improving the perfusion gradient across the kidney. And you sometimes have to hold your nerve, and you sometimes have to realise that the next day's eGFR is already baked in. It's not about what the next day's eGFR is, it's what the one is 2 days after that. If you're convinced they're still wet, you just have to keep diuresing them. Now, at the same time, if they're cold, you stop everything else that could be making them cold. This is the sort of situation where you have to stop a beta blocker temporarily. You have to stop an ACE inhibitor. You don't have to necessarily stop them if the patient's warm, but if the patient's cold and hypotensive and wet, stop everything, stop the doxazosin, and stop all these amlodipine, and just focus on the diuresis. If they're anemic, try and optimise their hemoglobin. If they're hypoxic, try and optimise their oxygenation. Let them have a tachycardia, because they probably need that. And then patiently diurese them and hold your nerve with the eGFR. And if you're running into trouble, get help. There are some patients who you can't walk that tightrope with, and they're the sort of patients who you might need to think about referring for more advanced therapies. But for most patients, you can ride them through it. This chap, we got him diuresed. We were able to get him on dapagliflozin and eplerenone. We tested him with an ARB, and his blood pressure just crashed, and he was very unwell with it. And his GFR took a huge hit. And what we did then was we said, well, right, we'll stop the candesartan. We'll diurese him more and more and more. And we finally got him to the point where we thought he was euvolemic. And then we tried the candesartan again. He did tolerate it. And the difference was that he wasn't then dependent on his renal autoregulation to maintain renal perfusion, that his perfusion had increased sufficiently that he could now tolerate a slight reduction in blood pressure because there was less back pressure on the renal system. So sometimes you have to pause, but it doesn't mean that they can't tolerate renin-angiotensin system inhibitors. It means that they may only be able to tolerate them when they're dry. And I think that's a really crucial point.
That's a really helpful case to go through that. And we started talking a bit about diuresis and the importance of that. And I think people do find this a bit tricky in clinical practice sometimes, particularly if you're running into issues with hypotension or AKI. And it's really helpful just to know that if they're still congested, if they're still wet, you just need to keep going.
I sometimes say to people, I'll just put up a slide that says diuretics are not nephrotoxic. There's this whole think AKI thing, stop the nephrotoxins, and that's wrong. First thing is to assess the fluid status. And if they're congested, then diuretics are the kidney's best friend. And they don't make the kidneys work hard. There's all this nonsense about how you're flogging the kidneys. You're not. You're just switching off ion channels that are highly energy dependent. So you're actually conserving energy in the kidneys with diuretics. It's not flogging them harder. I know we sometimes say that to patients, but it's not really what it is. I think getting out of that mindset and realising that with diuretics, it's not that they're intrinsically nephrotoxic, like maybe something like gentamicin. It's only nephrotoxic if you make them hypovolemic. If they're clearly not hypovolemic, then you can give the diuretic. And the other thing is, they're not really antihypertensives when you're congested. They're only antihypertensives when you're euvolemic. And so if somebody says, can I give the furosemide because the systolic blood pressure is only 85? Yeah, absolutely. Give it. What if it's only 80? Give it. Go on, just give it. Be confident in telling the nurse and staff appropriately, just looking out for the patients and making sure, despite the blood pressure, this is the right way to go. And often the blood pressure might even pick up as the really stretched, overloaded LV is just less stretched. Sometimes you can get a better cardiac. They've gone over the Frank Starling curve back to physiology days and bring them back down to the peak of that curve, and they can sometimes boost their cardiac output with less stretch.
Yeah, absolutely. And often you find that, people might be using sort of tiny doses of diuretics if the kidneys aren't good, and actually you paradoxically usually need higher doses of loop diuretics to actually have any sort of effect. So,
oh yeah, absolutely. And there's actually nothing paradoxical about it. The whole thing is that the drug's got to get into the renal tubules to work. That's where it works. So if you've got a low eGFR, you're not filtering blood as well, then you need a higher blood concentration to achieve adequate renal concentration. So yeah, you absolutely do need sometimes very high doses of diuretics in patients with significant chronic kidney disease or major congestion. And there's a congestion sort of trap, or a congestion hemodynamic hole, if you like, where you really need to dig the patient out of it, because the more congestion you get, that begets more congestion. You know, as you start to accumulate fluid, then you get that to the point where you've got reduced renal blood flow. Then you hang on to more fluid, more congestion, lower EGFR, more salt and water retention. That's often the point where the patient's tipping into hospital, where they're right in the throes of this vicious cycle, and you need to break it. And if you don't break it, if you only gradually increase the diuretic, then you're always playing catch up, and you're never getting on top of it because the congestion's always worsening. And conversely, if you're bold at the start and if you break that congestion cycle, as you come back down and the renal blood flow is increasing, then the maintenance dose that you need will also come down. So you need to get a sort of soft landing. The more congested you are, the less the diuretics work. The more euvolemic you are, the lower dose of diuretic you need. But I would say that if the patient has been decompensating on the treatment they were on with diuretics, that you need to somehow change the trajectory, either with addition of evidence-based therapies, but usually with a boost to the maintenance diuretic as well, but not the sort of doses you'll need to decongest them in the first place.
Absolutely. And can we talk a little bit about dosing and route for loop diuretics? So I don't know if you find this, but often you might find that someone's normally on, 4 milligrams of bumetanide normally at home, and then they come into hospital, get IV furosemide, but it's a 50 milligrams, and there's no actual increase in dose there. And I just wondered if you can give some top tips on thinking about that increase in dose to decongest when people are presenting at the front door. And also there's often sometimes differences in opinion on IV boluses versus IV infusion, and I'd be interested to hear your thoughts on that as well.
You can often get patients out of that congestion cycle if they're deteriorating with a period of high-dose oral diuretics before they hit the front door. But the oral diuretics, bioavailability reduces as your gut congestion increases, and sometimes it needs intravenous therapy to get around that. And if they're in hospital, usually you may as well give them intravenous treatment to make sure you hit things appropriately. I would say, as a rough rule of thumb, think about the equivalent IV dose of their oral dose and double it. A good starter for 10. So if somebody's on 4 milligrams of bumetanide, that's going to be, roughly 160 milligrams of furosemide. So might give something, maybe not quite double it in that situation, but maybe give something like 200 milligrams IV twice daily of furosemide at that point. You can go up if you need to. On the bolus versus infusion, there have been some studies on this. It's nice. The trials of diuretic treatment, there's one called the DOSE study, sort of suggests there's no difference really in the efficacy of bolus versus continuous infusion. My preference is bolus because we're in hospital, we're not in a clinical trial, and what happens is cannula comes out at midnight, isn't put back in till 9 a.m. the next day, and so patients missed out on all that diuresis. Plus, I sometimes think achieving a sort of higher concentration in the bloodstream is important just to get more effective diuresis. So for practical purposes, I think bolus is better.
Yeah, I feel the same for exactly those reasons, that infusions are just a nightmare on the wards.
There's no benefit to them. You're not escalating treatment by putting them on a continuous infusion.
Our rule of thumb on sort of IV oral furosemide is that IV is, twice as potent or strong as oral. Do you go by that rule?
There's such a huge variation in bioavailability of furosemide when you take it by tablet, but roughly speaking, you might get, in a good scenario, maybe 40% bioavailability. So you're going to have twice the efficacy straight away if you're giving it intravenously, and remembering that that bioavailability may be way, way down in patients who've got a lot of mesenteric congestion.
Yeah. I just wanted to talk a little bit about what your approach is to understanding the response to diuretics. And we've talked a little bit about JVP and clinical examination already. Is there anything else you're looking for when you're thinking about that?
So when you've got a patient who is lucid and able to speak to you, the best test, I think, is to ask them, did you pee a lot more with this? And if they say, I'm running to the toilet, load, stop, you're on the right track. And if they're not, then you've not got a high enough dose, and there's no point carefully monitor the weight every day and just see it's not changing, or you can just ask the person, no, I've not noticed that I'm peeing. My rule of thumb is patients who can tell me, I want to know if they are having an effective diuresis, and if they're not, I need to escalate it somehow. Monitoring weight, is helpful in severely congested patients where you think you maybe got about 20 kilos or so to lose and you can keep track of where you are. In the short term, for patients who are not quite at that sort of really grossly edematous stage, it might be a rough and ready indicator, but not that great. You can look at edema, but the venous pressure is much more helpful. I tend to titrate to the venous pressure. If the venous pressure is still up, I keep going. It's nice to see it coming down, but still being elevated, and you can, it's like a sort of spirit level. And then I do my hepatojugular reflux trick to see if I should keep it going a little bit longer. Monitoring the bloods, you've obviously got to keep an eye on the EGFR, but as I said, what you might see is a sort of U-shaped appearance in EGFR, perhaps the other way around, inverted U, whereby as you diurese them at first, their EGFR will actually improve paradoxically. It doesn't always, but it often does. If it improves and you keep aggressively diuresing them and then it starts to go the other way, then maybe you've hit the limits. So sometimes that's a useful pointer as well, I think. But although you've then got to go back and assess them clinically, and you might say, oh yeah, I think they are drying out. Or you may say, no, they're still wet, and maybe something else has happened. Somebody's given them a dose of an ACE inhibitor, they're brewing sepsis or another problem, a UTI, something like that. There can be other bumps in the road with the EGFR, so it's not hard and fast. If the kidneys are going off, I look at the blood pressure chart first, and you often see that there's had a period of hypotension, that in that congested state, they just can't tolerate. That's often the issue. It's the blood pressure that's causing the AKI combined with the congestion rather than the diuretics. So always look at the trends in blood pressure, always think about other possibilities for why the EGFR might be dipping. Somebody might have given them trimethoprim and that's increased their tubular secretion of creatinine or something like that. There's always these silly things, but you've got to take them into account. So it's not easy. Balancing diuretics is the hardest part of heart failure by a mile, and knowing when to introduce therapies alongside diuretic is where maybe the skill is, but where the fun is as well.
Yeah. And quite often we might find, you've been trying to diurese them with loop diuretics, you're not really getting anywhere, and you might introduce some other things like thiazides or SGLT2I. Can you talk a little bit about that when you're thinking about that and how you're doing that?
I know we've not talked yet really about the sort of disease-modifying therapies in HF-rEF. I know we're going to get to that. But a couple of them, just to mention up front, there's beta blockers, which everybody will be familiar with. Now, beta blockers you definitely don't want to give to the severely congested, unstable patient. You could really tip them into markedly decompensated heart failure, cardiogenic shock. Beta blockers one you have to be super cautious with. But when they're still wet, there are a couple of those 4 pillars we're going to come on to that are actually really helpful. So there's SGLT2 inhibitors, which have a diuretic effect. It's a kind of variable diuretic effect, but can often be quite significant. That's in part because of where they act in the kidney. They act very proximally in the tubules. So sometimes resistance to diuretics could be because all the sodium's been reabsorbed even by the time the filtrate gets to the loop of Henle. You've missed your opportunity. So they work very proximally, so that can sometimes be really helpful. So you get a disease-modifying therapy that is helpful when they're still wet, so that's really handy. Another one I'd mention is spironolactone or eplerenone. I tend to use eplerenone, particularly in males, because it's got better side effect profile. Often the enemy when you're aggressively diuresing people, it's not hyperkalemia, it's hypokalemia. And many, many, many more people die from hypokalemia than hyperkalemia. Even potassium in the sort of normal range, but below 4, is a big risk, increases your risk very significantly for ventricular arrhythmias. You want that potassium above 4, ideally 4.5 or thereabouts. And so adding in potassium sparing diuretic that also has disease-modifying properties like spironolactone or eplerenone, that's helpful when they're still wet and prevents hypokalemia. So it's really one to think about there. Bit trickier in patients with very bad kidney function, obviously, tend to be very problematic in patients with EGFR below 30. You've got to be really careful if you're using them there. If things are going well, it's great to introduce them. That just helps the process along. If you're not winning with the diuretics, you've got them on high doses of furosemide, they're still refractory, they're still not having a good diuresis. Generally speaking, adding spironolactone 25 milligrams is going to do nothing because it's not really a diuretic, much of a diuretic at that dose. Maybe if you're going to put it up to 100 or 200, you might get a diuretic effect. That can be helpful. But if you really need something to kickstart the diuresis, then a thiazide's the best. There is metolazone, but there's benzothiazide as well, which is really helpful on its own. It's a rubbish diuretic, it's very weak. But when you've got somebody who's on long-term loop diuretics, then you get sort of structural changes in the distal convoluted tubule, you get hypertrophy of those cells, and they take on a greater proportion of the work in terms of sodium reabsorption. So then if you hit those receptors in a patient who's already on loop diuretics, and that turbocharges the diuresis. The addition of a small dose of bendrafluozide can really just get the diuresis going. But you can go higher. You don't go higher than 2.5 for the management of hypertension, but you can go all the way up to 10 for diuresis purposes. Rare that somebody would need that sort of thing to keep them on maintenance euvolemia, just sometimes patients in the very end stage. But that can get the diuresis going very, very nicely. The only other one I'd mention at this point is acetazolamide, because there was something called the ADVOR trial last year showing that acetazolamide is an effective add-on. It's very effective decongestant. I think it's probably for the same reason that SGLT2 inhibitors are. It's where they work. They are the only diuretic that work proximally before the loop of Henle. I've not used it much in practice, but it's now one that I've got in my toolbox if I really need to reach for it.
Yeah, thanks. That's helpful. I've certainly found that short-term thiazide is often the thing in the hospital at home setting, is often the thing that really kickstarts it. So yeah, I think that can be useful if you're stuck. And you kind of alluded to this already, but I think it might be good just to think about this specific heart failure with reduced ejection fraction management, so the 4 pillars that you alluded to. So imagine our patient has been effectively diuresed, they're now euvolemic, they're established on oral diuretics, and we're thinking about discharge. They haven't been started on anything, and it's thinking about, what we need to start, when, how. Let's start with your kind of typical non-complicated, non-frail patient first, and then we can think a little bit about the more tricky situations.
Yeah, sure. I guess almost everything we've been talking about so far, you could apply to heart failure of any flavour. And now thinking more specifically about heart failure with LVSD. So there's 4 pillars of therapy, 4 core treatments that can sort of modify the disease substrate, improve prognosis over the longer term. Born out of very fruitful research in the 90s and 2000s that showed ACE inhibitors and beta blockers substantially reduced mortality and other adverse outcomes in patients with HF-rEF, and could also lead to reverse LV remodeling, where your LV ejection fraction could actually improve, where you could prevent further LV decompensation. This is all based on this neurohormonal hypothesis of heart failure, that it's a vicious cycle propagated by upregulated, unhelpful neurohormonal systems, and if you block them, you can unwind that process. Quickly, we added an MRA into that Rails trial back in 1999, showing a whopping reduction in mortality with the addition of just a small dose of spironolactone. And then subsequent trials in the post-MI LVSD setting and more stable, less unwell patients with severe LVSD has shown that MRAs are hugely effective. And actually, in terms of mortality reduction, they're actually slightly better than ACE inhibitors. And so this led to the sort of triple therapy idea for heart failure. And then there were 2 more advances in more recent years. First of all, there was sacubitril valsartan, or Entresto, which is an ARB like valsartan, which we know is roughly equivalent to an ACE inhibitor, with an extra molecule added on called sacubitril. Sacubitril inhibits an enzyme called neprilysin. And neprilysin is interesting because, as well as the bad guys in heart failure that we're trying to block, there are also helpful systems that are upregulated in heart failure. And some of these are a bit obscure. There is the natriuretic peptide system that I mentioned before. Then there's other ones. There's one called the apelin APJ system that I did my PhD on, and it's been completely forgotten forever. Substance P, bradykinin, adrenomedullin, all these things, all these weird systems, but they cause vasal relaxation, they promote sodium loss, they prevent myocardial fibrosis and hypertrophy. So they're really helpful. So neprilysin breaks those down. So a neprilysin inhibitor upregulates those good guys whilst also blocking the bad guys. The reason that the sacubitril had to be combined in a single molecule with an angiotensin receptor blocker is that neprilysin also breaks down angiotensin 2. So if you only give it alone, you'd be up-regulating the renin-angiotensin system, and nobody wants that. So they combine them together. They tried it with an ACE inhibitor. It looked promising initially, but then that drug led to lots of angioedema because ACE inhibitors also upregulate things like histamine and bradykinin. But when they combined it with an ARB, they hit the sweet spot and you didn't get any angioedema, and you got a big improvement over an ACE inhibitor. So tested head-to-head against an ACE inhibitor in Alpril and absolutely whacked it in terms of reduction in cardiovascular mortality, heart failure hospitalizations, reduction in all-cause mortality, and better symptoms. So Entresto then became the renin-angiotensin system inhibitor of choice for most patients, and we'll come on to the non-frail patient in a sec. The last new advance recently was SGLT2 inhibitors, sort of discovered fortuitously. Nobody was expecting them to be helpful, but noticed in the cardiovascular safety trials that they seemed to really reduce incident heart failure. Was it just like they had diuretic effect? Was there something else going on? So they were tested on top of all other therapies, even on top of everything else. These drugs reduce cardiovascular death, heart failure hospitalisation in patients already on optimal standard of care with HF-rEF. So then we've got the 4 pillars and the change in mindset about, starting one, up-titrating it, starting another, up-titrating it, reassessing, maybe thinking about adding another. That's all gone. And you say, well, look, there's an urgency here. There's a real urgency because patients have got a terrible prognosis once they're admitted with decompensated heart failure. The rates of death, readmission are sky high. So you need to do everything as quickly as possible. So we try and get as many of these 4 pillars instituted as soon as possible. And it's a real missed opportunity if the patient leaves hospital without any. What order do you add them in? There's no set order. Depends on the patient in front of you. As I said, if they're still on the wet side, you can safely add in an SGLT2 inhibitor. You can usually get away with an MRA. If they're hypokalemic, an MRA is going to be the first one to add in. If they're hypertensive, if they've got loads of blood pressure, then Entresto is a great option. It's probably the most powerful antihypertensive agent we've got, which is also its weakness in some situations, sort of frailer patients. And the beta blocker is the one you have to be super careful with. For the decompensated patient, the beta blocker is usually the last, though possibly the most important. 50% reduction in sudden cardiac death with a beta blocker versus no beta blocker in HF-rEF. So it makes me nervous discharging patients without a beta blocker, but sometimes you have to, but we then want to get those patients seen again super quickly so we can start to introduce it. So in hospital, try and get patients on at least 2 of the therapies before they go home. Try and think about it before they're fully decongested and ready to go home with those treatments you can add in before the patient's ready to go home so that you can then add in any other therapies at the end. Crucially, it's the discharge planning and the transitional care. It's what happens next. Who's going to see them once they get out of hospital, and who's going to make sure that we titrate their therapies and optimise them.
I guess that brings on to follow-up. So you've managed to start maybe 2 or 3 of the 4 pillars at kind of a low dose in hospital before discharge. Tell me about follow-up. What should we be doing for these patients?
In Lothian, our approach has been to try and see anybody who's been admitted or attended the front door. Ideally, try and see them within a week of discharge, certainly within 2 weeks. The more unstable they are, the more quickly we see them. And we've got some hot clinics we can do that with. But that's where the real value of the heart failure nurse team comes in, who've got expertise in titrating these therapies, adding them on. It's their bread and butter. They know exactly what they're doing, adjusting diuretics. And it's such a really good service. In Lothian, they only cover patients with HF-rEF at the moment. That's where the original business case came from. There were actually randomised controlled trials to show that heart failure nurses save lives with this service. So we've got a really strong case for heart failure nurses in patients with HF-rEF, and the moment we're not resourced, they're already very stretched. So sometimes people would get a bit frustrated at that, but we can only do what we can do. So at the moment, the service only applies to HF-rEF, and that's similar in a lot of different places. But that's the key. So if we know about the patient in real time, we can start to plan when we're going to see them next. Not a letter that comes 2 weeks later. It's too late.
Yeah, so basically anyone who's been admitted with HF-rEF should be getting early follow-up with the heart failure specialist team.
And I know in Lothian, you've got to remember the median age of the heart failure patients is 81. And a lot of the patients who are admitted are more elderly and frail. There's a really great role here for hospital at home teams for those sort of patients who are able to support patients getting home. Sometimes give them IV diuretics at home till they're decongested and monitor, get them back established on oral diuretics. And then when they're perhaps a bit more stable, if it's appropriate, hand over to the heart failure team. I'm really pleased that we've managed to get in Lothian much better working with the hospital at home teams. They now come to our MDT, and we've got really open channels of communication, and we can hand patients back and forward as appropriate.
Yeah, I think that's really helpful. And this is like, the bread and butter of hospital at home really is the heart failure is a lot of it. So having really strong links with heart failure teams is so important. And I guess a little bit about more complex situations with the 4 pillars. I mean, mainly in terms of me, it's sort of the orthostatic hypertension, frailty. It can be really tricky. And I don't know whether you've got any tips for this population. in my mind, it's, things that they can tolerate that might help with their congestion often work well. They may not be able to tolerate Entresto, and, you just need to accept that. Do you have any thoughts on that?
It's all about trade-offs and balance of risks at that point, isn't it, Kat? These patients generally don't get into clinical trials. I know Professor McMurray, who did the Paradigm trials, very proud of telling audiences that the oldest patient in that trial was 97. But that wasn't your typical 97-year-old, and there weren't any other 97-year-olds in the trial, really just a talking point. And the issue here is that you cannot just superimpose the evidence onto these patients because they've got much higher competing mortality risks. These therapies aren't necessarily going to make them live longer if they've got other multiple comorbidities. They might die of something else. And also the risk of harm is higher. I'm not someone who advocates an algorithmic 4 pillars for all approach. I think that's wrong-headed. Shouldn't be cavalier in that way. I think you need to think about each individual treatment specifically and whether it's going to be worthwhile. I think sometimes the best tolerated medications in these patients are SGLT2 inhibitors because they don't cause much postural hypotension. You can give them safely in chronic kidney disease, even down to eGFR, so 20 or so, and you can continue them even if eGFR keeps dropping. There's no need to stop them. They're a really good option if you want to try something. I think MRAs in the elderly are actually really helpful as well. Got some of the best evidence base in older patients. I was doing a review on that a little while ago. They've, I think, got a pretty good trade-off, especially in those patients who are needing quite a lot of diuretics. Again, it's hypokalemia is going to put them into AF or worse. And so they can be really helpful. Entresto isn't for everyone, and I think you really have to be very, very cautious in the sort of older, frailer patient who's at risk of falls and who's at risk of adverse consequences from those falls. But if you're thinking about Entresto, particularly if they're hypertensive, it's not a definite no-no. But maybe try candesartan first at 4 milligrams, see how they tolerate that. Maybe up titrated to 8. And if they're tolerating that, then maybe think about low-dose Entresto, but don't jump in with it. And don't use it at all if they're going to be somebody who's going to be falling, breaking their hip. Then beta blockers, people don't thank you for the beta blocker, even though it saves their lives. It's the one you've got to try and persuade people to stay on. It's one you've got to cajole them a little bit. And so quality of life perhaps becomes a bit more important. I would say that there's a trial of Carvedilol, which is sometimes a slightly better tolerated beta blocker. It's got vasodilator actions as well as beta blocker actions. It's got venodilator actions, which can prevent decompensated heart failure. It's probably the beta blocker with the best evidence in heart failure of all the beta blockers. And even in patients with MIHA class 4, very advanced heart failure, one of the interesting things was that patients who were on Carvedilol had spent 40% less time in hospital than patients who weren't taking it. So if you can keep patients out of hospital, that's a really good thing, and keep them in their own home. So we can give up completely. Maybe just a tiny dose of Carvedilol would be something to think about.
That's really helpful. You're absolutely right. It's all about that individualized decision making and realistic medicine and thinking about what's going to benefit that person's sort of quality of life. And being out of hospital is such an important one. Once someone's admitted with something, then they have a hospital-acquired infection, then they fine, and then they're in for months, and it's a nightmare. So yeah, that's really helpful. And I didn't know that about Carvedilol, so that's really interesting. I'll definitely think about that next time. Great. Okay, well, we'll maybe round up there. We've had a really good chat. Usually we kind of end with any sort of 3 top tips or take-home messages about heart failure that you want the listeners to take away. Any thoughts?
3 top tips. First one, I hark back to what I said earlier, volume status. Get better at the JVP and use it to adjust your diuretics up or down as needed, and don't always automatically stop treatments, particularly the diuretic when patients have impaired kidney function. Number 2, think about heart failure. Have it on your radar. Not everybody who comes into hospital with breathlessness has got a PE or a lower respiratory tract infection. Not everybody with a small troponin rise has got an ACS. Think about heart failure. If it's on your radar, then you're much, much more likely to diagnose it. And if you're struggling to diagnose it, there's plenty of help available. And I guess that's my third point, do something. I think heart failure is one of the best opportunities in all of medicine to make a difference. Such a potential to improve someone's life and save their life. And anyone can be the person who initiates that, because we need someone to push the button sometimes to say something needs to be done here. We've got support. There's the heart failure nurse team, there's cardiology team, there's the REACT hospital at home in West Lothian, hospital home teams across all of Lothian in all different regions. So do something, take the initiative, And if you're not sure exactly what to do, get help.
Thanks so much. I certainly learned a lot from that episode, so thanks so much for chatting with me, and I hope the listeners have enjoyed that too.
It was a pleasure. Thanks.
On Friday the 24th of January, we'll hold our Medical Trainees Conference at the college in Edinburgh. You can also join online. Organised by the RCPE Trainees and Members Committee, the conference is free for RCPE Collegiate, Associate and Student and Foundation members. We'll cover managing medical emergencies, think about cases that have changed our practice, move on to navigating complexity in ambulatory care, and finish with clinical lessons. We'd love to see you there. Book now on the RCPE website.